Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 183 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, JKL, a 38-year-old male presents to your accident and emergency department. He has a history of past illness significant for nausea, vomiting, fatigue, jaundice, and abdominal pain that worsened over the past 7 days. JKL is otherwise in good health. He has a past medical history significant for schizophrenia. With regard to his sexual history, he is a man who has sex with men, MSM, he resides in a homeless shelter, drinks 3 beers per day, and occasionally snorts cocaine. He has no current medications. He has no known drug or food allergies. His pertinent vitals include a body temperature of 98.9 degrees Fahrenheit, a heart rate of 82 beats per minute, a respiratory rate of 14 breaths per minute, a blood pressure of 142 systolic and 82 diastolic. He rates his pain as 5 on a scale of 1 to 10, his height is 5 feet 7 inches and he weighs 80 kilograms. On physical examination, JKL is generally alert and oriented without the presence of confusion. His skin suggests jaundice. HEENT points to scleral icterus. His abdomen is soft, tender, and he has hepatomegaly. His extremities are not edematous. Regarding his genitourinary system, he has dark urine. His pertinent labs include, a glucose of 99 mg per deciliter, a BUN of 21 mg per deciliter, a serum creatinine of 1.3 mg per deciliter, sodium levels of 132 milliequivalents per liter, potassium levels of 3.3 milliequivalents per liter, chloride of 95 milliequivalents per liter, albumin of 3 grams per deciliter, AST of 258 international units per liter and ALT of 997 international units per liter, T-Billy 2 mg per deciliter. Regarding his serologies, he is HIV negative, anti-HIV IgM positive, HBsAg negative, HBcAb negative, HBsAb positive, and HCVAb negative. Based on JKL's serologies, what would be the most appropriate interpretation? Would it be A. The patient probably has an acute HIV infection, or B. The patient requires HIV and HBV vaccination, or C. The patient is immune to HIV through vaccination, or would it be D. The patient is naturally immune to HIV as a result of exposure? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. The patient probably has an acute HIV infection. This patient probably has an acute HIV infection based on the positive anti-HIV IgM. He probably is not naturally immune to HAV as a result of exposure because he does not have a positive anti-HAV IgG. In addition, the patient would not be exhibiting signs and symptoms of acute infection. This patient does not need immunization against HBV because he has a negative HBsAg, and HBcAb, and positive HBsAb, indicating that he is immune due to prior HBV immunization. The patient probably has an acute HAV infection because of his positive anti-HAV IgM, and he has epidemiologic risk factors, that is, he is an MSM and a drug user and is symptomatic. In addition, the patient's homeless status is another risk factor for HAV and was associated with an outbreak in 2017. Please advance to the next question. And the next question reads, regarding the clinical scenario above, which of the following is the most appropriate recommendation for this patient at this time? Is it A. Treat with immune globulin, or B. Provide supportive care, or C. Initiate Twinrix, or is it D. Initiate Havrix? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Provide supportive care. This patient probably has an acute HAV infection based on being symptomatic with anti-HAV IgM, which is a self-limiting disease, so supportive care is the best recommendation. Immunization using Twinrix is not appropriate because the patient will develop antibodies to HAV that provide lifelong immunity after the acute infection resolves. Immunization using Havrix is not appropriate because the patient will develop antibodies to HAV that provide lifelong immunity after the acute infection resolves. He does not require immune globulin at this time. Please proceed to the next question. And the next question reads, GOS, a 25-year-old patient is newly diagnosed with HIV. With a CD4 cell count 647 cells per millimeter cubed, HIV RNA viral load of 34,900 copies per milliliter, and hepatitis B virus (HBV) co-infection HBV DNA equal to 74,849 international units per milliliter, AST of 89 international units per liter, and ALT of 104 international units per liter. The weight is 92 kilograms, and his height is 67 inches, and the serum creatinine 1.45 milligrams per deciliter. This patient has no known drug or food allergies. The patient's HIV-1 genotype has the K103N mutation. Refer to Stanford database. So my question to you is, which of the following would be the most appropriate once-a-day oral treatment to initiate in GOS's case now? Would it be A. Tenofovir disoproxil fumarate, or B. Tenofovir disoproxil fumarate plus emtricitabine plus efavirenz, or C. Tenofovir alafenamide plus emtricitabine plus bictegravir, or would it be D. Abacavir, lamivudine plus dolutegravir? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Tenofovir alafenamide plus emtricitabine plus bictegravir. Although lamivudine provides some activity against HBV, it is not a first-line treatment for patients with HBV due to its low genetic barrier to resistance, and its use is associated with a high rate of resistance. Abacavir does not exhibit activity against HBV. In addition, prior to initiation of abacavir, an HLA-B*5701 must be documented as negative. Therefore, abacavir plus lamivudine plus dolutegravir is not appropriate for this patient. Tenofovir alafenamide is a preferred antiviral agent for the treatment of both HIV and HBV infection. Additionally, emtricitabine provides activity against HBV, although it has a low genetic barrier to resistance and its use is associated with high rates of resistance. However, tenofovir alafenamide plus emtricitabine plus bictegravir is a complete antiretroviral regimen that provides adequate first-line coverage against HBV. Therefore, it is the most appropriate choice for this patient. Tenofovir disoproxil fumarate plus emtricitabine plus efavirenz is not an appropriate choice because the patient has a K103N mutation conferring resistance. Additionally, the patient's creatinine clearance is less than 50 ml per minute, and the dosage of tenofovir disoproxil fumarate should be adjusted in patients with renal impairment. Finally, this combination is no longer a first-line recommended therapy for the management of HIV. Using tenofovir disoproxil fumarate (TDF) monotherapy to treat HBV alone is not appropriate because resistance could develop to TDF, especially because HIV is present. Additionally, the patient's creatinine clearance is less than 50 ml per minute, and the dosage of TDF should be adjusted in patients with renal impairment. Please advance to the next question. And the next question reads, KTM, a 35-year-old patient newly diagnosed with and treated for HIV and hepatitis B virus HBV co-infection achieved virologic suppression of HIV and HBV. KTM's current regimen consists of tenofovir alafenamide, emtricitabine and dolutegravir. KTM's labs at the last visit were significant of the fact that the HBV viral load was elevated to 2,984 international units per milliliter and the HIV RNA was undetectable. The labs today are significant of the fact that the HIV viral load is undetectable. HBV DNA is 10,003 international units per milliliter. AST and ALT are 67 and 99 international units per liter respectively. The CRCL remains stable since ARV therapy was initiated. So my question to you is, which of the pharmacotherapeutic interventions listed below would be the most appropriate for KTM at this time? Would it be A. Add pegylated interferon plus ribavirin and continue current HAART, or B. Add entecavir to current HAART, or C. Add adafovir to current HAART, or would it be D. Discontinue current HAART and initiate alternative HAART that includes lamivudine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Add entecavir to current HAART. The current HAART should be continued because the patient's HIV viral load is suppressed. Adding adafovir to tenofovir alafenamide plus emtricitabine plus bictegravir is contraindicated because the structure of adafovir is similar to that of tenofovir and the combination could cause severe renal toxicity. Treatment of the patient's HBV, which probably is resistant to the current ARV therapy, could involve a change in or addition to current ARV therapy. Because the patient's HIV is virologically suppressed, adding another agent is the preferred approach. Additionally, because the patient's HIV regimen is tenofovir alafenamide plus emtricitabine plus dolutegravir, adding adafovir would be contraindicated. Therefore, adding entecavir to current ARV therapy is the best choice for this patient. Avoiding interferon-based therapy is recommended because other viable treatment options are available. Please proceed to the next question. And the next question reads, TKP, is a middle-aged patient who will be starting hemodialysis at the beginning of next week and received complete immunizations for the hepatitis A virus, HAV and hepatitis B virus, HBV 36 months ago. You are reviewing the patient's hepatitis serologies, which were drawn this week in anticipation of starting hemodialysis. Hepatitis serologies are as follows: total anti-HAV positive, HBsAg negative, HBcAb negative, HBsAb is 6 million international units per liter, and HCVAb negative. So my question to you is, which of the following is the most appropriate recommendation for HAV and HBV immunization based on the serologies? Is it A. Wait 3 months and repeat the hepatitis serologies before giving any vaccines for HAV or HBV, or B. Initiate a combination of HAV and HBV vaccine series, or C. No HAV or HBV vaccines are needed because the patient is immune to both HAV and HBV, or is it D. Give a booster dose of HBV vaccine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Give a booster dose of HBV vaccine. This patient requires a booster dose of the HBV vaccine because the level of HBsAb is below 10 million units per milliliter. Although immunization was completed in the past, the patient no longer has immunity to HBV. The patient is immune to HAV based on the positive total anti-HAV. Although complete HAV and HBV immunizations were completed 3 years ago, the patient is immune to HAV based on the positive total anti-HAV, but not HBV based on the negative HBsAg and HBcAb and the undetectable HBsAb level. This patient is immune to HAV based on the positive total anti-HAV, so immunization against hepatitis A is not needed. The patient requires a booster dose of the HBV vaccine because the level of HBsAb is undetectable. Although immunization was completed in the past, the patient no longer has immunity to HBV. Therefore, the combination product is not necessary. Waiting to repeat the serologies because of the undetectable HBsAb before giving any vaccines for hepatitis A or B is not appropriate. Although immunization was completed in the past, the patient no longer has immunity to hepatitis B virus and requires a booster dose of the hepatitis B vaccine. Please advance to the next question. And the next question reads, a hepatologist is interested in initiating a patient with compensated liver disease on treatment for hepatitis B virus infection in the coming week and is inquiring about the various available formulations of tenofovir. So my question to you is, which of the following statements is correct? Is it A. Tenofovir disoproxil fumarate is associated with more drug-drug and drug-food interactions, or B. Tenofovir disoproxil fumarate is associated with less systemic exposure, or C. Tenofovir alafenamide may be used in patients with CRCL as low as 15 ml per minute, or is it D. Tenofovir alafenamide is associated with a higher risk of renal and bone toxicities. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Tenofovir alafenamide may be used in patients with CRCL as low as 15 ml per minute. Tenofovir alafenamide is associated with fewer adverse effects than tenofovir disoproxil fumarate, including bone and kidney toxicity. Because tenofovir systemic exposure is lower with tenofovir alafenamide (TAF) than tenofovir disoproxil fumarate (TDF), TAF may be used safely in patients with a CRCL as low as 15 ml per minute. The pharmacokinetic and pharmacodynamics parameters for tenofovir disoproxil fumarate allows for greater systemic exposure compared with tenofovir alafenamide. Tenofovir disoproxil fumarate is associated with fewer drug interactions than tenofovir alafenamide. Please progress to the next question. And the next question reads, BWM. A middle-aged cirrhotic patient is receiving glecaprevir plus pibrentasvir therapy for infection with hepatitis C virus, HCV genotype 3. So my question to you is, when is the earliest time after completion of treatment that is most appropriate to order a quantitative HCV RNA test to assess for sustained virologic response, abbreviated as SVR? Is it A. 12 weeks, or B. 8 weeks, or C. 6 weeks, or is it D. 4 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. 12 weeks, the earliest time after completion of HCV therapy when a quantitative HCV RNA test is appropriate to detect SVR is at 12 weeks and not at 4, 6 or 8 weeks. Please progress to the next question. And the next question reads, GAB, a 37-year-old female patient with HIV/HCV co-infection. The patient receives approval from her insurance company to initiate HCV therapy. She is treatment naive with cirrhosis. She is allergic to sulfur drugs and had anaphylaxis the last time she took a sulfonamide. She has a past medical history significant for HIV, HCV, and seizures. Her current home medications include levetiracetam 1000 mg orally twice daily, tenofovir alafenamide 25 mg plus emtricitabine 200 mg orally once daily, atazanavir 300 mg plus cobicistat 150 mg orally once daily. Her pertinent vitals include a weight of 197 pounds, a blood pressure of 110 systolic and 82 diastolic, a respiratory rate within normal limits, a body temperature within normal limits, a height of 65 inches. Her pertinent labs and diagnostics include AST and ALT of 102 and 111 international units per liter respectively, an INR of 1.8, a total bilirubin of 1.5 mg per deciliter, an albumin of 3.1 grams per deciliter, a platelet count of 87 times 10 power 3 cells per millimeter cubed, a CD4 count of 345 cells per millimeter cubed, HIV RNA undetectable HCV RNA of 754,970 international units per milliliter, and a fibroscan F3. Her liver ultrasound reveals hepatomegaly and splenomegaly. Her hepatitis C is genotype 2A/2C. So my question to you is, which of the oral regimens listed below is the most appropriate to initiate in GAB based on recommendations from the American Association for the Study of Liver Diseases, abbreviated as AASLD, and the Infectious Diseases Society of America (IDSA)? Is it A. Velpatasvir 100 mg, plus sofosbuvir 400 mg once daily for 12 weeks, or B. Ledipasvir 90 mg plus sofosbuvir 400 mg once daily for 24 weeks, or C. Glecaprevir 100 mg plus pibrentasvir 40 mg 3 tablets once daily for 12 weeks, or is it D. Declatasvir 30 mg daily plus sofosbuvir 400 mg once daily for 16 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Velpatasvir 100 mg, plus sofosbuvir 400 mg once daily for 12 weeks. Declatasvir plus sofosbuvir is an alternative regimen, but the preferred regimen should be used first instead of an alternative option. Although Glecaprevir plus pibrentasvir may be an appropriate regimen for treating HCV genotype 2, its use with atazanavir is contraindicated because atazanavir can inhibit the metabolism of Glecaprevir plus pibrentasvir. Ledipasvir 90 mg plus sofosbuvir 400 mg is not indicated for the treatment of HCV genotype 2, it is indicated for the treatment of only genotypes 1 and 4. Oral velpatasvir 100 mg plus sofosbuvir 400 mg daily for 12 weeks is the most appropriate treatment regimen for this HCV treatment-naive patient with genotype 2 based on the AASLD and IDSA guidelines and the lack of drug interactions. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 184.